Hello, welcome to Converging Dialogues. This is Xavier Bonilla. On this episode, I am very happy to bring the conversation I had with Frank Putnam. Frank is a psychiatrist, researcher, clinician, and teacher on health effects of violence and abuse. He is the professor of clinical psychiatry at the University of North Carolina School of Medicine. He has formerly been a professor of pediatrics and child psychiatry at Children's Hospital Medical Center, University of Cincinnati College of Medicine. He's worked at National Institute of Mental Health research program in Bethesda, Maryland, where he's done many studies and a big longitudinal study. And he has typically focused on child and adolescent psychiatry, but he has also been one of the experts on dissociative identity disorder, formerly known as multiple personality disorder, which is what we do talk about in the conversation, although we don't emphasize it or focus on it as much. But we do talk about his one of his major books that he's written, which was absolutely fascinating. I really enjoyed it. So we start the conversation by talking about obviously his background and many of the things that he has done and how he has been able to kind of do some of this work on developmental stages and how we have this really long longitudinal study to look at trauma and what that looks like through time. So it's fantastic. But we mostly talk about his book, The Way We Are, How States of Mind Influence Our Identities, Personality, and Potential for Change. So we talk by defining what are states of being. We talk about the continuous self. We talk about states of being in infant and child development. We talk about different states in rapid cycling of bipolar disorders. We talk about how important memory is for the self. We talk about personality, the big five with self and states of being. We talk about how mental disorders look like through a state model. We talk about the fragmented self and different types of therapy that try to connect with that or work with that, I should say. We talk about trauma, PTSD. And yes, we do talk about dissociative identity disorder. We talk about psychedelics, peak experiences, and many other topics. Frank is a wonderful person, wonderful human being. He has got one of the nicest personalities I've talked to. I really enjoyed my conversation with him a lot. He's obviously a absolute treasure trove of knowledge and information and wisdom, and really just listening to him was a big honor in a lot of ways. And I really enjoyed our conversation and really, kind of sharing our worlds. Obviously, he's in psychiatry, my world's in clinical psych, and so really having a nice conversation about some of the clinical things, but also trying to understand this idea about what it means to be human, what it means about personality, what it means about ways that we can change. And I really found a lot of value in this conversation personally. And I think it's something for everybody in the conversation. As always, you can find this conversation and all past and upcoming conversations at convergingdialogues.substack.com. Get over there, subscribe, follow, share with your friends, engage. You can do the same at YouTube. And now I bring you Frank Putnam. I am here with Frank Putnam. Frank, thanks so much for coming on the podcast. I'm greatly looking forward to talking with you.
I'm pleasure to be here.
Yeah, of course. Yeah. So you have written a wonderful book, really good. I enjoyed reading it. The book is called The Way We Are, How States of Mind Influence Our Identities, Personality, and Potential for Change. I know it's a few years old now. I know you've written a bunch of other things as well. So maybe just kind of give us your potted biography professionally, just kind of what your background's in, some of the stuff you've written on, and anything most current or recent that you've been thinking about.
Okay, well, I think of myself as a child abuse psychiatrist in the sense that I have been working in the area of child maltreatment for 30 probably close to 40 years.
Mm.
And that brings you in contact with a lot of different kinds of things, including starting out with dissociative disorders. That's kind of how I got there.
Mm.
So my undergrad was Wesleyan University. I went to MD, PhD program at Indiana University,
Nice.
then went to do a residency at Yale. And following the residency at Yale, I went to NIH for a clinical fellowship. And there's where I encountered really my first case of, not because I had seen other cases, I just didn't recognize the disorder, DID, dissociative identity disorder, until I sort of thought my third case or so at the NIMH. And there I began to study dissociation in the context of really working with bipolar disorder. I think it was very important because there I was seeing another group of patients who were rapidly changing state. And that got my interest in states and states of consciousness going. But I also got very interested in the effects of child maltreatment on the development of self and personality. And so after 20 years at NIMH, I went off to run a child maltreatment program that had both clinical parts of it, forensic parts, but a lot of research also. And there's where I really looked at a lot of the effects of child maltreatment on the developing child, including a lot of endocrine problems, a lot of cognitive issues. We're actually now looking at a lot of genetic changes, epigenetic changes in our sample. So I've been working in that area for 35, 40 years. My major study started 35 years ago and still goes on.
Wow, that's great.
So I went from childhood with these individuals, about 200 individuals, to about half maltreated, sexual abuse girls. All of them were female, and to now many of them are grandmothers. And
Wow.
we've looked at their children, and we're looking at them, and we actually spent a lot of time with their mothers. So we have 3 generations. So that's led to my doing a lot of policy work, spending some time testifying to legislatures and government and about various kinds of models for treatment and intervention. So that's kind of my career in a nutshell.
Yeah, that's quite the storied career. That's fantastic, especially having a big longitudinal study, different cohorts. That's fantastic. That's great. So you've written this book. I know you've written some other things, but we talked about the way we are mostly. I guess so. You're in this book positing a kind of framework, I guess, is how I see it, of these states of being. So could you tell us about states, I guess, of being? Many people will think about, you can look at philosophy and ontology in terms of being and essence and things like that. You can also look at kind of maybe more in the clinical world. We look at traits and states and things like that. So how do you mean various states of being and states of mind, and I guess how they're similar and different?
Okay, well, I'd say you're always in some state or other. Okay, and the idea of state is very ubiquitous and used in many different ways, and it's kind of very confusing. And I'm very interested in sort of really taking it down and looking at what exactly is a state. And that means looking across a whole variety of states, whether you're looking at drug-induced states or dissociative states or depressive states or mania states or anxiety states or, epiphanies. There are all sorts of states. And I'm interested in extracting what are the state principles that define a state. And so, definitions are always tough. Where I went and searched for my definitions, and what did I say? Okay, here we go. The concept of a state of mind, mental state of being, is a transient, multidimensional mental configuration of variables that shapes mood, perception, cognition, memory, physiology, and behavior, and is frequently associated with a sense of identity, basically. And that's drawn from looking at a variety of different kinds of states. of mind, and particularly this idea of multidimensionality. That over and over again, as I look at the data, what you see is states are defined as sort of clusters of variables, and some of those variables are cognitive, some of them are physiological kinds of variables, but they're sort of discrete spaces or discrete points, mostly kind of fuzzy little balls if you actually plot the data, but they occupy areas of state space that are quite unique. And
This is really interesting. I like how you define that. Something I want to flag now so I can remind myself to get to it later is, if we're always in a certain type of state, state of being or state of mind, I guess the question I have is, how do we have a kind of continuous self, right, in terms of identity? Again, I know we'll probably get to that later, but if you want to kind of just flag it here, I had a conversation recently with a social psychologist out in I believe Stanford. I might be wrong on that. Brian Lowry. He's great. We had a wonderful conversation. We had two conversations actually about this, and he thinks the self is all a social construction, right? But he just goes all the way with it, right? Which I give him a lot of credit for doing, because he just he makes the claim and then he said, well, explain it. What's the continuous self? Like, how is it? What's there? If there's nobody in the car pulling the levers and driving the ship, well, what is it, right? There's no self in there, So I guess for you and your framework, how do you understand kind of, if we're in different states, how that connects with self and identity, and is there a continuity of a person, of an identity, or of a self, even with different states?
well, yes, I mean, this is exactly the issue, which is how do you go from all these different states to something that seems like a relatively smooth operating personality,
Mm-hmm.
or a sense of self. So, in my kind of definition, I think of states as being sort of unique, transient kinds of configurations that move from one to another. I think of personality as being the integration of those, but also the external experience by other people of you.
Mm-hmm.
And self as being sort of your internal experience of yourself. That is, so that personality, and you can point to many cases where people have what appears to be this kind of personality, but have a very different sense of themselves than people might think of them. They might say, well, he'd never do that, or whatever. But it's so self is really the internal experience of yourself, which may be more fragmented than people on the outside experience. And personality is really that social thing that everybody sees that they think of as you. And states are what goes into all of that. And the issue is, how do you get that integration?
Mm-hmm.
How do you bring those states together to make sort of a continuum, or more or less a continuum? I think the issue is that nobody's got that down perfectly. Nobody sort of smoothly slides from state to state to state, always remembering what they just did or said or whatever. And that has to do with a series of kind of cognitive structures that we find over and over again, depending kind of on your discipline. So if you're a developmental psychologist, you call this executive functions.
Right.
If you're a cognitive psychologist, you call it metacognition.
Mm-hmm.
If you're a dynamic therapist, you call it the observing ego. It's okay. It's something that helps you look at yourself as you are, brings in memories from one state to another, helps you have that with that continuity. And and therein lies certainly opportunities for kind of pathology or disorder. If you have failures to do that, and in particular, the dissociative patients I work with, that's one of their major failures, is they have not integrated these states. In fact, they've actually heightened the individuality of those states. And that's why you get these identity states that sort of see themselves as different people. But we see identity fragmentation in other disorders. Does that make sense?
Mm-hmm. Yeah. One thing I was curious as you were talking about is, where do you see is, I guess, the role of the body? Now, I think some people may overemphasize the body, But a lot of people may underemphasize the body, or still this kind of strange duality of sorts of like, mind body thing, or like the brain is here and the rest of the body is, different. I guess, how do you see in terms of that integration of all of these different states, the centrality or not of the physical body, and how that is kind of connected with everything, with our central nervous system and peripheral nervous system, et cetera. What's the centrality, I guess, of the body for you, or not?
Well, that's why I like the term states of being, because it sort of encompasses the mind and body sort of thing. Now, I certainly have a pathway from states to kind of the body, and that goes through the kind of micro states all the way to identity states to sort of personality
Mm.
in that sense. That goes on. That the I think there is actually the issue of duality can sort of be taken apart in little chunks.
Mm.
It's often presented as if it's either or. But if you go from microstates to basically sort of brain states to identity states to personality, you begin to see how the biology can move into a state of mind.
Mm. Mm. Yeah, it's interesting how, in trying to understand things like a self or identity, or even some of the work that's done now with consciousness, we still kind of keep coming back to some of the ways and how things continuously integrate, how there is continuity, how, whether the body is there, how much and to what extent. I guess the question here I have is about how this all kind of uh, of sorts. So was kind of the origin story here, right? So you talk about in the book various stuff that many people may be familiar with, such as there's much research that's been done on infant development, sort of the critical stages, sensitive periods, attunement, attachment, things like that. I guess, in just briefly, in terms of how we get states of being, the big question I have here is that always just the case since birth that we're going through these different states? Or is it something that is a kind of developmental thing, that as we get older, these are longer periods, or this is where we see more abnormalities? Or how do we see it in terms of a developmental framework of how states of being kind of come online, if you will?
Okay. So states are detectable even in utero.
Mm.
Okay. And many a mother will tell you, it's the baby's quiet now, the baby's moving around now. We can document that on ultrasound. So even the fetus is showing distinct states over the course of a day. And when a child is born, a healthy, normal child, neurotypical, as they say, is um, generally has a number of very distinct states that can be coded, and they're discriminated by things like a heart rate and respiration, EEG, eyes open, vocalizations, a variety of external objective signs you can use to sort of pot that multidimensional part of kind of putting the state in this piece of state space or that piece of state space. And so states are always there. There have been pretty well studied in infants, and they actually a number of sort of interventions for infants, for example, helping mothers get infants to breastfeed, is built around recognizing what state the infant is in, and can that infant latch on, and helping the infant acquire the latch state, so it's there from birth on. Now, states change over development. I mean, that's one of the things that goes on. And we see evidence of that change in things like attention span, ability to recover from disruptions of state, those sorts of things. So there are markers. The problem is, after about age 3, states get difficult to study because you got this kid running all over the place, and so you up till about age 3, there's pretty good data actually on infant states, and to the point where they're actually useful interventions. in that. And we can see that again at different points in development. But again, another really big place where states kind of emerge in behavior is in adolescence. And that's when you start seeing what's called the identity crisis. And you see adolescents who are different with different contexts or different groups of friends. I'm this way with this group of friends. I go with that group of friends. I'm very different, and here, which one is the real me? And that's part of this infant. You can see that process going on. And I think adults can recognize states in themselves that they often make very conscious transitions, like you're going from your work state to home state, sitting in the car listening to the radio turned wide open or something like that. People have various kinds of techniques for eliciting states that they think are going to be appropriate or where they want to go to, whether it's a cocktail or a run or whatever sort of thing. So they're always there. People have sets of states. They're more or less integrated. And we can look at a number of pathologies and say, there are disorders where this integration breaks down, whether the mechanisms for changing states are aberrant. People get stuck in states, or they have slippery states and they can't maintain a particular state in a situation where there's metacognitive issues. They can't take what they know from one context and move it to another context, those sorts of things.
I guess the question I have there is real quick is kind of, I guess, sort of a footnote is, I mean, obviously there's a much ado that's made with, how much of genetic involvement is here for everything for us as humans. And then obviously there's the environmental and cultural context and socialization and things like that. So there's all of these different ways. I guess in infants in the beginning, how much is, I don't want to say innate because people read that as genetic or something else, but I guess where do we see, I guess, kind of at the bits and pieces of it, what's contributing to kind of these states? Is it just all of it, certain, things with the mother, things in environment, and then maybe some of those, such as socialization, might have a larger role to play in, middle childhood, late childhood. But I guess, what do you think are the kind of components of various states that are there?
Well, the infant stuff has been, as I said, fairly well delineated. And the sort of a newborn infant has basically about 5 states. 2 of them are sleep. One is regular sleep and one is sort of irregular sleep. And then there's a state called alert inactivity, where the infant is awake, but is not moving around very much. And then there's a waking activity kind of thing. And then crying is actually defined as, in these models, as a distinct state based on kind of vocalization. But you see the blood pressure changes, you see the heart rate changes, and kind of an alert activity sorts of state. And the infant is cycling through these in about 2 hours. Okay, and we know that as sort of the normal infant sleep-wake cycle. Now, something comes along and disrupts that cycle. They wet their diaper, they're hungry. Then that's the role of the caretaker, comes in and attends to the problem and provides soothing and often resets that model so that it's going on. And as you develop, more states are added and sort of more pathways among those states are added. Kinds of things. So the caretakers are extremely important. And what we see in some disorders is that where there's been severe attachment problems, the people tend to go into dissociative states. There's very strong correlation, remarkably, actually, like 50% of the variance over 18 years is explained by the issues of poor attachment in 2 studies, and those are hard studies to do because you have to measure the attachment when they're 18 months or something, and measure it again when they're 18 years.
No, that's definitely Fascinating. I want to ask you about some of the DID stuff and a few other things. But I guess before that bit of it, it sounds like there's these cycles as you're talking about in infants, which are kind of well established. But is there a kind of I don't want to say a mirroring of sorts, but there's also the sleep cycles we know about our sleep stages. So when we are
Yes.
unconscious, right? So I guess talk about how about sleep and how you understand that as different states as well, whether you can go into REM sleep or non-REM sleep or but just the typical 4 or 5 adult sleep stages.
Exactly. Well, this is actually the example I use a lot because pretty much everybody knows about sleep.
Mhm.
And, for years and years and years, sleep was regarded as you were asleep or you're awake as a unified state. And then in the 50s and 60s, you had people like William Dement who began to break it down into what they called stages. And um, what we see in the regular sleep at night in somebody who's healthy is, in fact, a cycling through these stages 3 or 4 or 5 times, where they go from awake to drowsiness into stage 1, stage 2, stage 3, stage 4, into REM, often a little awakening after REM, and then reset the whole thing, and with some lengthening of the REM cycle over the course of the night. And so this is one of the kind of principles here is that sleep is a state, but it's made up of substates, which are those, and each of those is sort of physiologically distinct. So that you can measure the differences and actually make on an instrument and basically say this person is in stage 3 or stage 4 or whatever kind of thing. So you see that in lots of different things. It's just very distinctive in sleep, which is a normal state. Now, again, when we have pathology, you can have difficulty switching into sleep, or you can have problems with narcolepsy where people fall asleep when they're not supposed to fall asleep. You see these sort of levels of pathology, whether it's the states or whether it's the mechanisms that switch them into states, whether they're to some extent dysfunctional ways attempting to deal with that. I mean, I see a certain amount of substance abuse as really maladaptive attempts to manipulate state.
Mm. Mm.
Uh,
It's interesting how there's this we have these kind of cycles, as you will, these states, whether we're conscious or unconscious, willing or unwillingly. I guess kind of like what you were saying in the beginning. I'm curious. We can talk about two things here before we go back to the part on the self. Is one thing you talk about in the book and in various places, but you talk about kind of the rapid cycling seen in states with people that have bipolar. Now, I'm a little fuzzy on this. I don't know if still in the clinical literature we still use rapid cycling as a term. I know that was on the old DSM-4. In my clinical work, we used it when I was in training, but I don't hear it used as much anymore. But either way, there are for listeners, rapid cycling is this thing for folks that have bipolar as a as the shortening of the interval between a manic or hypomanic and a depressive episode, so that the point of what's the word I'm looking for, refractionary kind of period of sorts is lessened, so that way basically you're having your return to baseline, whatever that may be, is shortened and shortened and shortened as you're more continuing to cycle through mania, hypomania, or depression. And so in terms of where we see abnormalities, if you will, or dysfunction, if you will, in states such as in this example with bipolar, what does that tell us about folks that are switching states too fast, or where it's dysregulating their kind of homeostatic kind of way of interacting with others or themselves in the world?
right. So what I was on a unit for 3 years that sort of collected and studied rapid cyclers, and rapid cyclers in the sense of they switch back and forth between mania and depression, often over a period of a few days. So bang, 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 like that. And so one of the things that convinced me was that it was possible to go from being profoundly depressed to being manic in the blink of an eye. And which said that you don't have to make this very slow journey out of depression, for example, to get out of the depressive state, and which is, of course, composed of all sorts of substates, if you think about it that way. And I think that's what we're starting to actually see with some of the new interventions, like the RTMS and some of the new drugs, like the ketamine, and some of these infusions, which is that you don't have to wait 6 weeks for the drug to kick in. You can actually change people's state within 48 hours or 24 hours or something like that. So it says that possibility is there. To really kind of kick out of states. The question is, what do you take the person from to where do they go? And when we were doing it, it was always difficult to control. We could get them out of depression, but bang, they could go into mania, and which wasn't very helpful. So, and you see that with some drugs. Some of the antidepressant drugs all of a sudden kick people into mania. So, and there's a case where there's kind of an instability in the switch mechanism and kicks them into another spot of state space. So that's what really impressed me. Plus, looking at things like panic attacks. Panic attack is a state. Comes on very quickly, very consuming experience, very unpleasant experience for people. It usually fades over time. So it usually decreases so they feel less and less panic. So you may have a very quick onset within a minute or so, and it may take 20 minutes or something to sort of run its course. And that identifies a different principle, or a principle that's worth sort of bringing out here, which is the way into a state is different than the way out of it. And if you look at switches between state A to state B, it's different than state B to state A. And the example I often use is waking and falling asleep, that you fall asleep differently than you wake up. Typically, people wake up being and they may take a while to fall asleep with a couple of slipping in and a couple of myoclonic jerks kind of thing. So the way in and the way out is different usually.
So one thing that's coming to mind here when you're talking about this, which will kind of dovetail into my next question, which is, so is there a kind of ceiling? Again, that would be different, I would assume, for different folks, but is there a ceiling on how many states someone can be in? And second to that is, when we're talking about states, this isn't just affect or mood or anything. It might be encompassed within that, or mood or affect might be encompassed in that. But we're talking about state in a more kind of global sense, or the kind of gestalt of where the person is at, not just this is a change in mood or affect or something like that. So I guess, how many, is it kind of an infinite number of possibilities kind of thing? Or do people kind of have like a kind of nucleus of sorts of like the kind of major states they kind of go in and out of maybe differently? But how do we, from the literature that we know, how does it usually present for different folks?
Okay, so first of all, I'd say affect is sometimes a marker for a state. So, extreme affects can be whether it's like anger or sorrow or something. So often states are named by kind of the predominant dimension. So if the dimension's affective, if the dimension is motoric, it might be catatonia. So the states are named differently, but they all have this stateness quality to them, as I talk about it. So can you have infinite number of states? I guess maybe. I mean, I think of this idea of state space, that you've got kind of a range of variables, and that a state is sort of a kind of a fuzzy point in that, because the states kind of wax and wane over time as a sort of build themselves up, and as they sort of dissipate and bleed into the next state, kind of thing. But generally, people will have states that are related to context, and we're talking about normal, neurotypical kind of stuff. So you might have a set of states that go with work, or you might have a set of states that go with going out on a date, or being with kind of thing. So you would have kind of clusters of states that go, and every once in a while, maybe something would expand your states. You would do something that you'd never done before, and you'd have new states that you'd never experienced before. Kind of thing. And I think there's a drive to do that. I mean, we see that in children, this idea of, hanging upside down or twirling around on the swing, or, getting dizzy. They're kind of exploring different states and doing that. And so there's sort of a drive in many people to try something new, do something different, and explore new states.
Yeah, no, that's I like the way you explain it, because it does kind of give almost like there's these scripts or schemas of how we what there's a state of being in a particular environment or context with certain people, which it's obviously going to look different for each person, but it's interesting to see that variance of how it presents. I want to go back to the idea of the self, which we were talking about. So one thing about that you bring up in the book, which I really want to ask you about, is how much of our identity and sense of self is connected to the memory of ourselves, right? I think there's this interesting thing about how we know who we are based on the memories of how things are. Like, what does it mean to be me? Well, I have to usually go in my mental Rolodex and think. I mean, I don't do this all the time, but I'll think about, like, when I was 5 and 15 and 25 and 30, and I'm going in my memory bank to say, like, oh, I have this memory of myself, whether it's accurate or not, isn't it? But there's this idea of these memories. How much is there's it's a hard objective subjective kind of claims here, but how the general question is, how much of our memory of ourselves is important for our identity and how we understand our sense of self and our continuity?
I think it's very important, kind of thing. And the issue of continuity is extremely important. And that comes back to this issue of integration across states. To how good are your metacognitive functions at taking information and memories from one state and making them available in other states. And so you see pathology, again, expressed by failures here in those sort of extreme cases, DID, where the individual doesn't have that continuity across states, often has these protracted amnesias, for example, and so doesn't remember behavior that they engaged in, doesn't remember sort of how they acted. And so you have that kind of fragmentation of identity or fragmentation of self. And you see that not just in DID, you see it really in bipolar disorder, where people they're very different in the depressed state than they are in the manic state. If you ask them to tell you about themselves when they're manic, they're going to tell you one whole set of their wonders, and you ask them during the same question when they're depressed, and they're worthless. So they have very different senses of self in those different states.
So I guess the question there is that for amnestic patients, right, people that have various amnesias, especially for long-term memory, I guess it's not it's not that they don't have a self, they just can't remember what that is. Is that, or, and we'll talk about trauma in a minute, but is that is the empirical claim that there is still the self that is there and that has continuity, but that almost doesn't matter if you can't remember it and access it and integrate it well? Or is that too much of a value judgment that I'm placing there. What do you think
No,
about
I
this?
think the issue is how well is your self integrated. If you have a fragmented self,
Hmm.
that is,
Hmm. Hmm.
that you find yourself whichever way the wind blows, you go, kind of thing. That's one sense of self. Well, I don't know what I'm going to do. I have to wait till I get there, kind of thing. Whereas other people would have that sort of guiding principle. I know if I got to this situation, this is what I would do. Some people don't have a lot of control over that self part, how they're going to behave or act or something. They really sort of find themselves doing things they don't really know why they did them or how they did them. They may have very fuzzy memories of what they did, kind of thing, or they may not remember it all. The memories are there. You just have to access them, and you can access them through truth serum amytal. You can access them through hypnosis. You can access them through therapy. There's a number of ways to get to that. But the degree of integration is the feature there. And so there are a lot of people who don't know who they are because they're everything. They're whatever the situation demands.
Mm-hmm.
They're kind of chameleon-like. And that's their sense of themselves, is they can't count on themselves because they don't know what part of them is going to show up.
Mm-hmm. So where does, I guess, for you, personality and temperament fit in here? You talk about it in the book, and how that is, similar overlaps or divorce from the self and the identity. You can talk about Big Five if you want here. I mean, I've talked about Big Five personality model here. I mean, I've talked about it on the podcast. So, I mean, how do you see it, as incomplete or not enough, and maybe just kind of give the kind of state model of personality and how that commiserates or not?
All right. So, I knew we'd get to the Big Five.
You're not a fan.
Actually, I think the Big Five does its job for what it does, and that it's a valid way to look at things. It sort of tells you where you are now. You're this dimensional model. You've got these scores on these different dimensions, and this is kind of who you are, and it's relatively predictive of, are you trustworthy? Are you open to experience? How agreeable are you? Are you neurotic? Those sorts of things. But it doesn't tell you how you got there.
True.
Sort of thing.
Mm-hmm.
And then you've got developmental models that are very much kind of caretaker based in terms of things like attachment and attunement and learning to internalize or interject those things like self-soothing behaviors and recovering from states and figuring out what state's the appropriate state to bring out in a particular situation, like you're being taken to church. Well, how do you behave in church versus how do you behave at the stadium with your dad, who's rabid fan or whatever? You've got these very different sort of institutional expectations of what state you should be in. Those are, and then there's dynamic models, which I don't find much support for, but people are into Oedipal complexes and things like that. But I think that the state model basically says, it's got the developmental piece. Your caretaker has a lot to do with sort of your ability to integrate across states and your ability to access information. I mean, early on, it's the caretaker who says, remember what we learned at grandma's? Let's practice that here. So I take what I learned in grandma's and I bring it to this particular context. And so helps you with that situation. But, there was another part to your question, but we'll get there, I guess.
Yeah. No, absolutely. Yes. So I guess with there's these ideas about the self that you've kind of covered the states of being. So I guess now where does it when does it go wrong when we have pathology or disorders or dysfunction? Kind of give us the overview of how the model works for understanding various disorders or certain states of pathology, and then we can talk about trauma and DID.
Okay. So I would stress that I don't think that all mental health problems can be explained through a state model, but I think there are some that it provides a valuable insight into things like bipolar disorder, anxiety, panic attacks, catatonia, dissociative identity disorder,
Mm.
things, those sorts of that are characterized by people getting caught in different states that are dysfunctional. So I kind of identify about 5 levels at which there's pathology or could be pathology in the state model, and again, which we could do interventions at those levels, depending. And so the first is the states per se. You could have depression, anxiety, dissociation, panic, anger difficulties, protracted grief, paranoia, and we often seek to disrupt those states. We seek to break the depressive state, kind of thing, to maybe substitute another state for that. And then there's disruption of those state cycles we've talked about a little bit, which it may involve people having kind of being stuck in a state like depression, or having difficulty staying constantly in a state and having flipping back and forth like the bipolar, rapid cycling bipolar. And there we did a lot of work on circadian cycles with these individuals, and sort of reestablishing that. For example, many of the depressed patients are very seriously lagged, in a sense. They have a day-night reversal often, so they're up all night and they're sleep during the day, kind of thing. And so you walk them around the clock and get them back in tune, and that often helps restore. So dysregulation of the state cycles, switching problem, that some people are easily sent over the edge, that they have a very sort of easily triggered switch mechanism. So you may have to work on that in terms of sensitivity or desensitizing them in some fashion, or maybe they're prone to rumination and you have to kind of break that up. So you can have a sort of slippery switch mechanism or a stuck switch mechanism. And then there's this metacognitive failure to integrate across states, which leads to problems with the fragmentation of the sense of self, in the sense that you can't trust yourself. You don't know who's going to show up at that situation. You can't often use what you've learned. So people say, I knew that, I couldn't get to it. Kind of thing. So you may have that information, but it's not useful to you because you're in a state where you can't access that information, kind of thing. So that's something that therapy is actually pretty good at, in terms of helping people learn to get to what and use what they know. And then there's kind of the maladaptive attempt to manipulate states. So taking drugs. Now, often you hear from many of these people, when I take drugs, that's the first time I feel normal, kind of thing. So that's often part of that self-medication process, is it really helps them maybe stabilize the state or deal with some of the kinds of things that are disruptive for the states. And then ultimately, what I'd call aberrant state architectures, that your series of cycles and moving among those cycles is somehow messed up. And that may be day-night reversal in some ways, or things like narcolepsy. So each of those is kind of a level where this model can go wrong and produce a problem. But we also have interventions that work at many of these levels. We just don't have an integrated model of using these interventions consistently. People tend to go after one level or another level. They're going to give them a mood stabilizer, but we're not going to deal with the integration stuff or those sorts of things.
Yeah. So when you're talking about the fragment itself, of course, I'm going to think of Heinz Kohut. I'm going to think of even some Carl Rogers. As a kind of so there's a lot of so for listeners, Heinz Kohut is the self psychology within the kind of a contemporary psychodynamic theoretical model for therapeutic treatment, kind of a updated, more well-rounded, using a different model of how we understand narcissism for kind of well, it's modern now, but I mean compared to Freud. So he was kind of doing this renaissance of Freud, but with just all the updates and all the things and his own stuff. And the fragment itself was a huge component for his theory, and that's where he comes up with the idea of the tripart model, which is the mirroring and the idealized imago and the twinship and all that stuff, which is rooted in some attachment stuff and out of object relations. And Carl Rogers is obviously within the existential humanist theoretical model with his person centered. And most people will know about kind of the unconditional positive regard and many of the other empathy, his other kind of therapeutic tenets, but his actual theory was pretty uh, thoughtful. It was deep and thoughtful in its own way, whether you subscribe to it or not. So, anyways, all that to say, there have, I guess, been, I don't know about currently, but kind of the kind of flagship, I guess, therapeutic theoretical frameworks have tried to use this idea of the fragmented self in a psychotherapy kind of framework to try and fix it, to manage it. There have been attempts, at least, of doing that. I guess for you, whether it's those that I've just kind of mentioned or others, how do you feel about advancements as opposed to just saying, "Oh, here's a mood stabilizer," and there you go. How do you feel about other types of therapies or whatever that have tried to, I guess, correct for that or manage or augment some of the fragmented states of self?
Well, I think that's very important, and that's much of what the kind of therapy you use with really fragmented people, whether it's the DID kinds of things, or some of the blocking on the very good therapy that's used often with bipolars from Linehan.
Yeah, DBT.
Yeah, and yes, and it's really I think the mood stabilizer may help a little bit, as do the anti-anxiety and antidepressants, but that doesn't fix the problem. It just kind of intervenes at this particular level.
Right.
So
Right.
I'm a relatively big fan of therapy.
Yeah.
Um,
That's usually how I explain it as well. As I say, sometimes people need meds, and meds is good because it helps, kind of clear the blockage of sorts. So it doesn't flood you, it doesn't overwhelm you because you can't really do work in kind of your standard talk therapy if you're too overwhelmed or too flooded with all of the symptoms there. So you kind of turns the volume down a little bit, kind of clears out the fogginess, and then you're able to kind of do some of the more uh, deeper work and try to at least manage and or correct for some things. So we're in full agreement there. Um,
yeah, yeah, we are. But I work with a lot with kids,
mhm,
and I don't give drugs to kids by and large.
mhm,
So we do this with other kinds of interventions with
mm,
the kids that have a lot of, positive regard and
mhm,
stuff like
mhm,
that, but also safety and security.
mhm,
Depends a lot on the age of the child, but those are the things that we would see as being extremely helpful in dealing with some of these kinds of issues in the
mhm,
children.
yeah. So I totally agree. So I want to ask, kind of from that as a jumping off point, because you've laid the kind of groundwork there. So let's talk about I guess trauma. There's the latest Bible definition, DSM-5 TR now has criteria for PTSD. Of course, we know trauma is definitely not just PTSD or acute stress. There's just obviously different models. Obviously, we both know Judith and her work. So I guess what is your understanding of how to conceptualize trauma um, within a kind of seen as almost as a state disorder of sorts?
Yeah, well, if you think about trauma, it often evokes a profound state. If you think you're about to die, this is an extremely powerful state to be in. If you are continuously being maltreated, it's a state that you see the maltreatment coming usually. And so often you switch into a state that's able to sort of tolerate that maltreatment process. I think the DSM. I have a lot of issues with DSM and always have.
Join the club. Join the club.
Although if you look at most versions, somewhere my name appears in there, usually as a reader or sometimes on a committee or something, but that's an attempt to make it better.
There you go. There you go.
It's one of the things I do is I show the residents, for example, I started my training in the year of DSM-2 or in the era of DSM-2. DSM-2 is 100 pages. Okay, DSM-5 TR is 1,000 pages.
Right. It's ever growing. We're going to need to have 2 volumes in the next one.
Absolutely. It's sort of slowly getting things right in my sense. I think for me, one of the major things was the recognition that PTSD with dissociation, which is now a category, is clearly different than PTSD without significant dissociation. We see that physiologically, that without dissociation, sort of response to traumatic stimuli are kind of hyperarousal, whereas with dissociation, response to traumatic stimuli are hypoarousal. That is, the person shuts down, heart rate drops, skin conductance goes down, all the kind of measures of arousal actually go down. This is the freeze part, it's really fight, flight, or freeze. And of course, freezing is the mechanism that young animals and people, children adopt in the context. They become frozen with fear. And that's adaptive at some level, but it becomes a maladaptive adaptation, so to speak, over time to trauma. So many things qualify as trauma, and it's very hard to quantify trauma in many ways or understand why something is necessarily trauma for this person, but not necessarily a traumatic experience for that trauma. So to a certain extent, you have to accept trauma as at face value, I think, and respect somebody's trauma story. But it's a very powerful induction of state that goes along with trauma. And then if particularly in our longitudinal study of incest, our average victim was abused once a week for 1 to 2 years, or once or twice a week for 1 to 2 years, somewhere around 100 to 200 molestations. Well, that's very different than a single episode.
Certainly.
That leads to a whole different set of adaptions. And then there's all other variables about what was done, who did it to you, that sort of thing. So there's a lot of, I think one of the things that I experienced working in the trauma field was people will say, well, what's a trauma disorder? Everybody's got trauma disorders. Everybody's got bad things that happen to them. And, statistically, everybody's got 1 or 2. There is a kind of a threshold effect, but also so many other things have to do with did you have safety? Did you have supportive caregivers, et cetera? So that, what may be traumatic for one person is not necessarily for another. But where we see in the dissociative disorders is this very early chronic trauma. This is always going on, often associated with a kind of you never know what that caretaker is going to do. Are they going to be nice to you? Or are they going to be nasty to you? And so you're looking, trying to figure out what's going on. And you often see these kids who have dissociative disorder sort of switch in anticipation of what they think is going to happen. So they bring out another identity state that can take it. So they'll have kind of Superman identity states or protector identity states, those sorts of things that they bring out.
Yeah. That's. I'm glad. I like the way you explained it. I mean, obviously, trauma is a multidimensional continuum thing. It's complicated. It's a lot going on. There's obviously resiliency factors. There's obviously potentially traumatic events. It is a tough network of things to kind of sift through a lot of the times. Of course, there's wonderful people like yourself and others that have worked on that. So I guess ask or answer this about dissociative identity disorder. I get asked about this sometimes kind of almost casually, and even within my colleagues in the field or whatever. A few things here. We can just kind of lay out, I guess, some of the general things first. But And so this is, as if I'm correct, used to be multiple personality disorder. I think they updated the term to dissociative identity disorder. And again, I'm not close to this literature, but I know there was question marks that it was pretty rare. It was hard to differential. Whereas some people even deny that it's a real thing. Like some people have denied that it even exists. You know,
More than some people.
yeah, right. And I think it is extremely, again, from the limited information I have on it, that it's rare. It doesn't happen. It's not like depression or anxiety or things like that. It's not as common as that, and in a diagnosable sense of the word. But I guess currently, I mean, I don't stay with this literature, but in 2023, like, what can we conclusively say at this point about dissociative identity disorder? Is it a real thing? Maybe some of the epidemiology rates, if you know it offhand. And then you can talk about some of the other things, such as people say, well, if people have that, and if it does exist, they all just have really extreme trauma. Is it possible to see someone with dissociative identity disorder and they don't have any, trauma in this kind of extreme sense? I guess some of the etiology is, I guess, what I'm asking about, how that comes to fully present. Yeah, just what are some of the kind of overview of this?
Okay. Well, certainly there's a lot of pushback about it. And I think the part of the problem is that people are pushing back against a stereotype that exists on sort of the Hollywood, the Sybil, the Three Faces of Eve. This is, not representative, but what most people think they know about it is based on this kind of either literature, the books, or
Yeah.
seeing the movies, or something like that. It's not really like that at all.
Hmm.
It's kind of like a very extreme bipolar, in the sense that this is a person flipping back and forth between different states of consciousness. These states are identity states as opposed to affective states. The getting to when, in my experience, and it's one of these things you can't experimentally test, but my experience, if the trauma occurs much after age 6, you don't get a person fragmented into discrete identity states. You may get a sense of personality fragmentation like a borderline,
Mm.
but you don't get George and Nancy and Harriet and the dolphin or whatever kinds of things. This is a result of very extreme trauma, repetitive trauma occurring in, usually starting around age 3, 4, something like that. Hundreds and hundreds of episodes in which the child is in pain, terrified, whatever, and has to create sort of mental structures or states that will deal with this, and also kind of sequester it in memory. I mean, one of the advantages of not integrating is that you're not terrified all the time if you can't remember what happened, sorts of things. So that is particular. There's a lot of data supporting dissociative identity disorder. It's like found all over the world. There are actually measures that are psychometrically as solid as the measures we use for depression or anxiety kinds of things. The profiles are really pretty much the same, whether you're looking at the population in rural Turkey or you're looking at um, middle class in the US. You've got the amnesias, the depersonalizations, derealizations, sort of the identity states kind of thing.
Mm.
So there's also an interesting physiology there. That is, there are differences across states. There are handedness differences. There are some very profound speech differences. That's what gives the sense of these identities being different people. I worked with a speech PhD person at the NIH where we taped them and did spectrograms, and we saw really some very dramatic changes. It had to do with the changes in the location of the vocal cords, that they moved up and down in the strap muscles, and so we could actually see these changes in the speech. We'd also get classic stutter in one personality and not in another.
Mm.
Those sorts of things. So there's there are real differences, but there are also continuities. If we look at things like habituation to a noxious stimuli, they habituate across personalities. So if you habituate one personality, that habituation goes across all the other identity states. So they habituate in the same way. But if you ask one identity state to learn a list of words and another one to learn a highly similar list of words, they keep them separate because they didn't hear or they're amnestic for that, whereas most people would get bleed through from one list to another, kinds of things. So we can demonstrate some tests in which they do better than your normal control. So there's something going on there, but it isn't the dramatic, way it is. And part of what you're doing is trying to break down those barriers. And generalize the information. And that's where a lot of the therapy comes in. But even without, I mean, you asked about the epidemiology. So we tagged on to a large national study, so supposedly representative Americans, not patent. It wasn't a clinical study; it was a general population study, and we found about 4% of the U.S. population reported extreme dissociative experiences. We didn't diagnose them, but we looked at, are they reporting amnesias? Are they reporting disremembered behavior? These sorts of things. And so that was about 4%. If you stand at the emergency room door and do careful interviews, you get upwards of 10, 12% of people presenting for admission. So it's much higher than people realize. It's not as rare and it's often mistaken for schizophrenia or for bipolar disorder, kinds of things, which is
wow. It's interesting. I again, I haven't. I think you're right. I think there's sometimes at a certain places in time, certain Hollywoodizations of of things, especially in the mental health field, are probably more harmful than good. I mean, I still have clients that will come to me and mention One Flew Over the Cuckoo's Nest. I'm like, my goodness, that movie's been out 50 years. Like, it's not like that anymore. We don't even have inpatient hospitals like that anymore. Like, it's kind of a extinct thing almost. So it's interesting how things just kind of live within culture and things like that. So it's interesting. Just real quick.
Just a note on that. I've worked with a couple of producers who are doing shows like Netflix or something. I cannot convince them not to use those models. And I say those are 50, 60-year-old models.
Right.
A great deal more. I'll take them down. I'll show them the experimental studies. They want to go back to that model. There's a perpetuation in the media that they, this is what they read, this is what they understand, this is what they're going to present.
Well, and I think it's just that. I mean, there's the sensational element of it that sells, and I think that's what people really kind of like, and it's the oohing and the eyeing. I mean, right? I don't know if you have. I've worked in forensic hospitals, and people will talk about Mindhunter, or they'll talk about the Zodiac movie, or all these things, and it's like it's not really like that. It's not, but people want to have the kind of sensationalism of it. So which is I think there's maybe a few things of exposure and people causing awareness for people, but I think most of it's just if you have to do a lot of correcting about it, I don't know how helpful it is, but so I want to ask towards the end here, it's a back part of the book, you talk about various changes. So I want to talk about peak experiences, meditation, even religious activities. But before that, I guess the question I have is about this kind of, I can't even say a renaissance for it. I mean, I think it's just kind of it's kind of like blowing the dust off of the research studies from 60 years ago and just trying to make up for lost time on psychedelic research, which is we're doing now, which you mentioned some of the ketamine, we're doing psilocybin shrooms, MDMA, etc. What do you make of this research, let's put it that way, and then also potential clinical use for certain populations for trying to um, understand or have I don't want to say curative, but a maybe therapeutic effect on various states for folks that have some things such as a PTSD or other things that it's I think been used for.
Right. Well, I think this is another example where we're learning that people can make very profound changes in a very short time, and that they can have experiences that really reshape them, and that personality is mutable in some sense. And then to some extent, that is accessed by creating some really weird state that allows them to have a perspective that allows them to make a change that they couldn't see or make in other situations. One of the things I see as I look across kind of this literature, particularly the kind of drug induced literature, is one, pretty much any drug that has powerful psychogenic or psychodynamic effects, or what am I trying to say, cognitive effects, can produce differences in states. And so you can get this with sedatives, you can get it with psychedelics, you can get it with amphetamines. So the drug itself isn't necessarily always that important. It's the idea that that drug produces some very profound state that's out of the individual's usual sort of experiences. So during World War II, there were studies there was a lot of this work with altered states for combat fatigue, and it was very successful. I mean, the cure rates were around 70%, or at least the return to the front line rates were about 70%, whereas during World War I, it was miserable. I mean, sort of nobody got over shell shock or whatever they wanted to call it at that time. Whereas but so they looked at, was hypnosis or sodium amytal better? It didn't matter. All it mattered was that you produced kind of an altered state in which you could work with that material that the person brought up in that context. And so that wasn't unique to those states. I think psychedelics are one of the most powerful state altering kinds of tools that we have. And so it's not surprising that we're seeing effects in things like trauma and PTSD and other situations like that.
Mm. Yeah, yeah, absolutely. And so, kind of along these lines, I mean, is if people find other types of ways of creating changes in various states, such as through meditation or mindfulness, sometimes religious activities. I don't know if hypnosis is still used like it was, 60, 70 years ago. But what do we make about some of these other alternative forms of how to change various states that may be dysfunctional or maladaptive or whatever to try and have more, functionality or to people to be more integrated?
Well, I think you see that there are a whole lot of different treatments advocated for PTSD, which says something, that nothing works for everybody. So some people get the psychedelic drugs, some people like to learn to play an instrument, some people like to meditate, some people like to take walks in the woods. But all of those are to some extent state altering experiences or places where you can go. And people who, when they're deprived of that, they really experience that as a real difficulty. And if they can't get their walk in the woods or their evening run or whatever they do, it really sets them back. So I think again, people will substitute states in those situations. Like, okay, I feel like this is coming on. I need to lift weights. Those kind of things that I get myself in a completely different state like that, or turn the record player up really loud and dance around the room, or do something that just really changes my state of mind as a sort of intervention there. Now, what to do more of the therapy, you need to go into the state and kind of desensitize that and do the integrative work. But a lot of people have hit on the idea that, you hear people say, this saved my life, until I took up pottery or something.
Mm-hmm.
I was,
Mm-hmm.
this saved my life. So they've learned to someplace where they can go that creates a more tranquil or peaceful or safe state for them.
Yeah. So the last question I have for you is, how do we take all of this information? There's a variety of disciplines that are kind of kind of moving in and out of here. How do we have all this understanding of our states of being, and how do we pragmatically, or in clinical or therapeutic settings, or just for ourselves personally, use that for our advantage to become more integrated, better humans?
So that's the big question. It really is. There's an enormous amount of information on states. It's very poorly integrated. There's a sort of whole set of mathematical models of switching in states, from the cellular level up to the sort of whole person level. There's a lot of neurophysiology on states and brain studies on states, and there's a lot of work in the clinical areas, and then there's the meditation and things like that. And I think it's kind of a mindset change. People have to really be thinking about states. We don't. Most of these people are not thinking about states. The clinicians are not thinking about states. They're dealing with what they know how to do. But I think by thinking about states, and particularly those levels, is it the state that I need to address? Do I need to address a problem with the switching mechanism? Do I need to address a problem with the metacognition? Do I need to address a problem with attempt to manipulate states through maladaptive ways like gambling or substance abuse? Kinds of things. That's where you get a more holistic kind of intervention. But no, it's very hard to get people to look at states. Though I often say, just listen, because people talk about states all the time. I was in this state of mind or that state of mind, or and my goodness, we're always interested in what state of mind the president was in, and what was his state of mind about this. So we talk about states of mind all the time. We just don't really think about the larger implications of that.
Yeah, no, it's there's a lot of work to still be done. So I mean, a lot of the stuff you've done already is I think is fantastic. Frank, thanks so much for coming on the podcast and giving me your time and energy. I greatly appreciate it. I loved reading your work and talking with you for a good hour and a half here was on this is just absolutely wonderful. So I can't say enough thanks for giving me your time.
Well, thank you. I enjoyed it. It was a fun conversation.
Yes, absolutely.